Welcome to the Lit Review on Congestive Heart Failure. Learning objectives. At the end of this lecture, you will be able to define heart failure and explain the difference between systolic and diastolic heart failure. You will identify symptoms associated with heart failure and be able to explain how we treat chronic heart failure and acute exacerbations of heart failure. First, we will define heart failure and explain the difference between systolic and diastolic heart failure. We will then overview symptoms of heart failure and the treatment of chronic heart failure and acute heart failure exacerbations. First of all, let us define heart failure. Heart failure is the clinical syndrome whereby the heart is unable to maintain adequate cardiac output to maintain normal tissue perfusion. It is important to understand that heart failure is a clinical syndrome, and the diagnosis is made clinically based on a combination of history, physical exam, and diagnostic testing. Because heart failure is a clinical syndrome, it is important to understand the common symptoms of heart failure. Fatigue and dyspnea, especially with exertion, are the hallmark features of heart failure. This is due to a mismatch between reduced cardiac output in heart failure and oxygen demand by peripheral tissues. As heart failure progresses, patients can develop volume overload, which can manifest in a number of ways. Volume overload in the lungs, called pulmonary edema, often causes orthopnea, which is defined as dyspnea while lying flat. Another manifestation of pulmonary edema is paroxysmal nocturnal dyspnea, where the patients get incredibly short of breath while sleeping due to pulmonary congestion. This wakes patients from sleep and often forces them to sit upright to catch their breath. Other manifestations of volume overload include weight gain, often from accumulation of edema in lower extremities or the gut. Gut edema may also manifest as bloating and poor appetite. Now that we know what heart failure is, clinically, we need to know how to classify heart failure. Heart failure is traditionally classified into two broad categories: systolic heart failure or diastolic heart failure. It is important to know the differences between systolic and diastolic heart failure because the causes and treatment of both disorders differ. In systolic heart failure, the ventricle has diminished function and no longer fully contracts, leading to a reduction in the ejection fraction, proportion of blood in the ventricle that is ejected with each heartbeat. In diastolic heart failure, the opposite problem is present. In diastolic heart failure, the ventricle is stiff or hypertrophied, which leads to impaired filling of the ventricle due to elevated end diastolic pressures. Note the difference between systolic and diastolic heart failure. In systolic heart failure, congestion occurs because the heart can't push blood forward as well as it should. Whereas in diastolic heart failure, congestion occurs because the heart is big and stiff, so it can't fill well. Both conditions lead to passive congestion in the circulation. As mentioned earlier, systolic and diastolic heart failure have different causes. Systolic heart failure is caused by disease processes that cause contractile dysfunction in cardiac myocytes. Examples include ischemic heart disease, valvular heart disease such as mitral regurgitation, aortic regurgitation, and dilated cardiomyopathies. Dilated cardiomyopathies are a heterogeneous set of disorders in which the left ventricle dilates and develops systolic dysfunction. Genetic disorders of the contractile apparatus such as defects in desmin and cardiac myosin, as well as various muscular dystrophies, have been implicated in dilated cardiomyopathy. Alcohol use in certain chemotherapeutic drugs such as doxorubicin have also been implicated. Metabolic causes of dilated cardiomyopathy include thiamine deficiency, hyper or hypothyroid, and adrenal excess. Importantly, viruses such as Coxsackie virus are also often implicated in the development of dilated cardiomyopathy. Diastolic heart failure, on the other hand, is caused by conditions that make the heart hard and stiff. Hypertrophic cardiomyopathy can be seen with certain gene mutations, often in sarcomere proteins. Hypertensive cardiomyopathy occurs when long-standing hypertension leads to left ventricular hypertrophy, which over time can lead to impaired diastolic filling and diastolic heart failure. Restrictive cardiomyopathy, caused by infiltrative diseases such as amyloidosis and hemochromatosis, can also cause diastolic heart failure. The severity of heart failure is graded on a 1 to 4 scale known as the New York Heart Association classification. In Class 1 heart failure, there is evidence of cardiac disease by imaging or history, but the patient has no physical limitation. In Class 2 heart failure, patients have no symptoms at rest but develop symptoms with ordinary physical exertion such as climbing greater than one flight of stairs or walking up hills. In Class 3 heart failure, patients do not have shortness of breath at rest, but have shortness of breath with less than normal activity, such as walking up one flight of stairs or walking on level ground. In Class 4 heart failure, patients are often short of breath at rest and get short of breath with even minimal activity, such as when grooming or bathing. The importance of the New York Heart Association class system is that many clinical trials rely on this classification system when deciding which subjects to enroll, and many of the advanced therapies we offer patients, such as cardiac resynchronization therapy, are limited to those with Class 3 and 4 disease. Physical exam findings of heart failure vary widely depending on which side of the heart is affected. In left-sided heart failure, we expect congestion into the pulmonary vasculature. We often see this manifest as an S3 gallop at the apex, pulmonary edema is evidenced by rails on exam, in extreme cases, Cheyne-Stokes respirations, which is intermittent apneic events caused by central breathing dysregulation. Right-sided heart failure manifests with systemic venous congestion, which is often seen as lower extremity edema, jugular venous distension, hepatomegaly, hepatojugular reflux, and in severe cases with ascites. If the right ventricle is large or dilated, a parasternal heave or lift may be appreciated. The treatment of chronic systolic heart failure involves a number of life-prolonging agents and a few agents used for symptom management. Importantly, all patients with heart failure must be on a salt-restricted diet and instructed about the importance of medication and dietary adherence. Through a series of large trials, a number of interventions have been shown to improve mortality in systolic heart failure. This includes the use of ACE inhibitors or angiotensin receptor blockers if ACE inhibitors are not tolerated, beta blockers, and aldosterone antagonists. In patients with Class 2 to 3 heart failure that maintain an ejection fraction of 30 to 35%, implantation of a cardiac defibrillator has been shown to reduce the incidence of sudden cardiac death. In patients with Class 3 to 4 heart failure, depressed ejection fraction and a QRS duration greater than 120 milliseconds, biventricular pacing with cardiac resynchronization therapy can improve mortality, decrease hospitalization, and reverse left ventricular remodeling. The use of hydralazine and nitrates are indicated in African Americans who are otherwise on optimal medical therapy and whose blood pressure can tolerate the addition of these agents. While diuretics and digoxin have not been shown to have a mortality benefit in heart failure, the addition of these agents to a chronic heart failure medication regimen is known to improve symptoms of volume overload and likely reduce the need for hospitalization. Despite optimal medical therapy, patients at times build up excess fluid due to their heart failure. Heart failure exacerbation can practically be defined as excess fluid accumulation to the point that urgent therapy or hospitalization is required. Causes of heart failure exacerbation include excess intake of salt, lack of medication compliance, myocardial infarction leading to acute worsening of cardiac function, tachy or bradyarrhythmias that lead to diminished forward flow, systemic inflammatory disease states such as infections, acute valvular abnormalities such as acute onset of valvular regurgitation, or due to medication effects. For example, diltiazem can reduce contractility and thereby precipitate heart failure exacerbation. NSAIDs can promote acute kidney injury, which may cause renal failure and subsequent fluid retention, which can then cause heart failure exacerbation. When a patient presents with heart failure in the decompensated state, you must make a clinical assessment of their hemodynamics. This is often accomplished by identifying if a patient is dry or wet and if their periphery is warm or cold. A dry patient does not have frank evidence of volume overload on exam. A wet patient does have signs of volume overload on exam, such as jugular venous distension, pulmonary edema, or lower extremity edema. A cold patient has compromised cardiac output, which promotes a high systemic vascular resistance that is manifest by vasoconstriction of peripheral capillary beds. On exam, these patients will have cool extremities. Warm extremities, on the other hand, suggest reasonable cardiac output so that peripheral capillary beds do not have to vasoconstrict to maintain an appropriate blood pressure. Ideally, a patient should be dry and warm. This means that they have no excess fluid and their extremities are well perfused. Patients in this category should have continued titration of medical therapies as mentioned previously. If a patient is warm and wet, such as having pulmonary edema or lower extremity edema, this suggests that they have elevated filling pressures and have reasonable cardiac output. These patients will benefit from use of vasodilators to reduce afterload, and diuretics to remove excess fluid. Patients that are cold and wet have elevated filling pressures but have reduced cardiac output, leading to vasoconstriction of peripheral vascular bed. These patients need careful titration of vasodilators and often need inotropic therapy to improve cardiac output while they are being diuresed. These patients often require the care of a heart failure specialist. Patients that are cold and dry pose a challenging problem. On exam, these patients will not look grossly volume overloaded, but their peripheral vascular resistance is high because of diminished cardiac output. These patients could either be intravascularly dry, meaning that they need gentle IV fluid hydration, or they can be intravascularly replete with high filling pressures, meaning that they need diuresis and possible inotropic support. Sorting these two issues out sometimes requires the use of a right heart cath to evaluate hemodynamics so that appropriate intervention can be applied. Diastolic heart failure, as opposed to systolic heart failure, has no proven therapies that improve mortality. Therapy is generally aimed at using beta blockade or calcium channel blockers to slow the patient's heart rate so it has maximum time to fill. Because of the unique physiology of diastolic heart failure, specifically the large stiff ventricle, patients with diastolic heart failure can develop episodes of acute onset pulmonary edema. This often occurs when there is a momentary rise in blood pressure, which makes it difficult for blood to fill the left ventricle, which in turn causes a flash of pulmonary edema to instantly develop. Treatment of flash pulmonary edema can be remembered by the mnemonic LMNOP. A loop diuretic will help to diurese the excess fluid. Morphine calms breathing and provides a vasodilatory effect, while nitrates reduce preload and improve coronary blood flow. Oxygen administration and positive pressure ventilation, often with CPAP or BiPAP, helps to recruit alveoli, reduce the work of breathing, and provides additional hemodynamic benefits that promote the resolution of acute pulmonary edema. In summary, systolic and diastolic heart failure differ in their pathophysiology as well as their treatment. Systolic heart failure is due to diminished pump function, and chronic systolic heart failure is treated with the use of ACE inhibitors, beta blockers, and aldosterone antagonists. Use of hydralazine and nitrates and ICD implantation are indicated for select populations. Diastolic heart failure is due to impaired filling of the ventricle due to a large or stiff ventricle, and no treatments are known to improve mortality in diastolic heart failure. Acute exacerbations of heart failure require evaluation of hemodynamics, that is, whether the patient is dry or wet and warm or cold, in order to guide therapy. Diastolic heart failure can cause flash pulmonary edema, which is treated with Lasix, morphine, nitrates, oxygen, and positive pressure ventilation. This concludes our presentation on congestive heart failure.